You can start, Delegate.
Okay. Welcome to the Health and Government Operations Committee. This is the Public Health Subcommittee. I want to start first by thanking our members who have done a lot of work. This session couldn't do it without them. Most importantly, thank you to Erin Hopwood, who is our counsel to our committee and deals with our emails, with our texts, with our calls and last minute requirements. And Erin, you are God sent and we couldn't do things without you. So thank you on behalf of the committee. And also my wonderful team, Edith Perry, who is the one that manages this call. I want to thank them and thank you for being available. So today we have House Bill 715, and I believe we're going to have another bill for discussion. And that is, Erin, what is that bill number?
I think Delegate Bagnall wanted to revisit House Bill 935, the Modernization Act that you discussed yesterday.
Yes, as well. So those are the only two items that we have on the agenda. Again, my name is Jocelyn Pena-Milnick, and I'm the chair of the Public Health and Minority Disparity Subcommittee. So we're going to start with the House Bill 715. And this bill, Erin is going to describe and walk us through it. Actually, if you will be so kind, members, and look at your reprint that is actually 3/25/22 at 4:52 p.m. That is the last version. So if you could please look at it, take a second to pull it up on your computers. I know Erin sent it to us via email, and then she's going to walk us through it. Okay, Erin, why don't you go ahead?
Sure. So in your reprint on Bill page 4, it requires MDH or an ASO, provides that MDH or an ASO may not recoup, require repayment, mitigate, or otherwise withhold payment from a healthcare provider for healthcare claims with dates of services in an estimated payment period or that were processed by a prior ASO and reprocessed by the ASO unless MDH or an ASO sent the healthcare provider a notice that includes the recoupment amount, the individual claims making up the recoupment amount, and the error that created the need for recoupment, and the information specified in sections 10.207 and 10.208 of the Health Government Article, and that is the Administrative Procedure Act. And at least 180 days have elapsed since the notice was sent. MDH or an ASO may recoup, require repayment, mitigate, or otherwise withhold payment from a provider for healthcare claims if at least 120 days have elapsed since the notice required was sent to the healthcare provider, unless the provider refutes in writing or appeals the notice, and the healthcare provider has not refuted the recoupment in writing or appealed the notice. Sorry.
Take your time.
Or the healthcare provider confirmed in writing every claim or encounter the healthcare provider submitted with the date of service in the estimated payment period has received a claim receipt in an industry standard format that accurately describes the status of the claim. No further actions are needed to correct any claim in a denied or unpaid status that has a claim date or service during the estimated payment period, or any claim that was initially processed by a prior ASO and then reprocessed by the ASO that was required to issue estimated payments, and claims have been applied correctly by the ASO to calculate financial liabilities the healthcare provider may owe to the state. If in determining whether to make the confirmation, the healthcare provider identifies claims that are not adjudicated or inappropriately in an unpaid status or are applied incorrectly, the healthcare provider shall notify the ASO's designated representative of the disputed claims. On receipt of a notice of disputed claims, the ASO must identify, correct, and adjudicate the disputed claims and deliver a claim receipt for every correct claim and an updated notice of recoupment or a notice that recoupment is no longer warranted. Within 60 days after receiving an updated notice of recoupment, the healthcare provider may appeal the status of any claims remaining in a denied, unpaid, or unpaid status under the Administrative Procedure Act. Such an appeal, in such an appeal, MDH has the burden to prove by clear and convincing evidence that the status of the claim is accurate. And if a healthcare provider prevails in whole or in part in the appeal, MDH must reimburse the healthcare provider for reasonable expenses incurred in connection with the appeal, including attorney's fees. If after appealing the status of the claims, recoupment is found to be warranted, the healthcare provider must fulfill the recoupment obligation within 1 year after the date of the final determination. There's also language stating that not later than 30 days after enactment of this act, MDH must report to Senate Finance, B&T, HGO, and Appropriations on the following information relating to healthcare providers who provide services under the delivery system for specialty mental health services. They must report on the differentials between estimated payments paid to healthcare providers from January 1st, 2020 to August 3rd, 2020, and the amount of claims submitted by healthcare providers for the dates of service during the estimated payment period, the amount of differential attributed to service disruptions due to COVID-19 pandemic, any plan to forgive healthcare provider balances because of service disruptions due to COVID-19, and the number and type of healthcare providers ineligible for forgiveness and the amount of funds to be recouped from them. There's also language stating that the bill is to be construed to apply retroactively and shall be applied to and interpreted to affect any claims made by healthcare providers for dates of service in 2019 that were processed or reprocessed after January 1st, 2020, or from January 1st, 2020 to August 3rd, 2020. The bill is also an emergency measure.
Okay, and so just so that we know, so that the committee knows why the bill is here, is because shortly after the new ASO Optum contract began, providers started to report substantial difficulties. Many providers were unable to register with Optum. Those that were able to register had difficulties submitting claims or had claims wrongfully rejected. Further still, the providers who did receive reimbursement noted inconsistencies. For example, claims paid were for the incorrect amount or without an explanation of benefits. The lack of an inconsistency of payments created significant concerns for the providers who need to make payroll and pay rent in order to keep providing services in Maryland. So to address the concerns surrounding the payments, on January 23rd, 2020, a notice was issued to providers by the then Secretary Rob O'Neill for the Maryland Department of Health that will be processing, they said they will be processing estimated payments to providers based on an average weekly payment in calendar 2019. These estimated payments continue through August 3rd, 2020. During the nearly 30 week that it took Optum to accurately and timely process claim, the department reported that it made a $1.4 billion in estimated payments to providers. Further complicating the situation is that the timing of these estimated payments coincided with the onset of the COVID-19 pandemic and its impact on service utilization. And DLS estimates that nearly 80% of the total estimated payments were distributed during the pandemic. So these have been the issues surrounding this bill. And this is why you have the bill in front of you as well. So now I would like as we always do in our committee, the sponsor of the bill to say a few words, but please keep it short and succinct. And then some of the advocates, and then I also will allow Optum to speak as well. As you know, everyone in this committee gets to speak, and then we will discuss it as a committee. You may ask questions. So in that order, I would like Delegate Geraldine Valentino-Smith to have a few words.
Thank you, Madam Chair, members of the committee. I will keep it brief. I want to really commend and thank your committee for continuing to work through these last days on this important issue. We did get an email, you may have mentioned it, from the AG's office confirming that they believe that we are good to proceed without any substantial claims on constitutionality, which I think is helpful. And I think it's probably best said then to let the providers go. I think Mr. Johansson had a technical amendment that he wanted to work with staff on. And I think that we'll go a long way now towards giving some certainty to the providers, take away some of their anxiety as to how they'll be able to adjudicate these conflicted claims. So thank you.
Okay, so who would like to go next from the advocates?
Madam Chair, I can go, if that's okay.
Yes.
Thank you. My name is Mike Johansson. I'm here on behalf of Shepherd Pratt Health System, as well as Gaudenzia. This claims processing issue has affected large and small providers alike. So we appreciate the sponsor and the committee looking at this bill. First off, this is just a process bill. This is not a forgiveness bill, right? This is just about getting it right. And I have a suggested amendment, which I was able to email to all the members here, but just to describe it to you briefly, on page 4 of the reprint, where the new language begins in B1, when you look at B1I, under that, it says the department or administrative services organization sends the healthcare provider a notice. What I would suggest is, what we're trying to suggest is these are all new notices. So we're trying not to say if you got a notice in March, your timeline started then. We want everyone to receive new notices with the information that's required. So I suggested on or after May 15th, 2022, the department or ASO organization sends the healthcare provider a notice that includes the information. It could be the effective date of the bill. I just thought with emergency bill, not knowing when it would be effective, it was easier to give a hard date than it was to say, upon the effect of the act. And
May
secondly,
I ask you one question, Mr. Johansson?
yes,
And I apologize because some person that is very important to the committee needed to come back in. Can you repeat what you just said, please?
sure. So the amendment on page 4, in section B1I, where it talks about the department or ASO sending the notice, I would suggest after I inserting on or after May 15th, 2022, the department or ASO sends the notice that's described. And the rationale for that is we have thousands of providers, some of whom have received various forms of notices. And what we're seeking with this start of this process is an official notice that everybody would receive that would contain all the required information. And then the timelines that Aaron described, such as having time to review before you seek an appeal, all starts on the same timeline.
Aaron, did you get that?
Yes, did. Thank you.
Okay.
And then secondly, striking a few lines below that in number 2, where it says the notice should contain information specified in 10207 and 10208 of the state government article. That is Administrative Procedure Act language. And what we're suggesting with this process, you shouldn't be appealing to the Administrative Procedure Act under this first notice. If you notice on number 5 on the next page, that's where the actual appeal comes in. So we don't want to confuse everybody by suggesting they should go ahead to the Administrative Procedure Act right away to an administrative hearing, because we want the informal process of dispute resolution to occur. We don't need a lot of lawyers engaged. We need everybody to get a real notice, have a chance to review it, do an informal dispute resolution. And only if you're dissatisfied after that process would you actually seek an appeal under the Administrative Procedure Act in number 5 on the next page.
And I want to give Aaron a couple minutes. Are you done with your technical amendments to see if they make, with all due respect to you, to see if they make sense to Aaron, which she's the legal counsel that I follow?
Yes, I'm done. Thank you.
No, they're completely fine. Easy to follow. Thank you.
Thank you. And does anyone else wants to be heard on this bill? Lori Doyle.
Thank you, Madam Chair. I just want to first off thank this committee for all the time they have put into this issue. Madam Vice Chair, you really summarized it very well. We provided services during the height of the pandemic because of the failure of the vendor to be able to do their contractual obligations, we ended up with these estimated payments. And all we want is a fair shake at saying that those claims that we submitted for services rendered can be fairly adjudicated. And that's what this bill is about. So we thank you so much for your time and for listening to us.
All right, anyone else wants to be heard before I open it to the committee? Okay, seeing no one, now is the time where our committee members, this is your opportunity to ask questions or express your concerns. Do you have any questions? Ms. Doyle, will you be so kind and lower your hand, please? Because it's a little confusing to me. Thank you. I appreciate you. So first we have Delegate Hill. Oh, actually Delegate Hill, and then I will call on Heather Scheck. You're muted.
Madam Chair, do you want me to wait until after?
Yeah, will you be so kind?
Sure,
Thank you so much. Thank you for your flexibility. Ms. Scheck.
Thank you, Chair. Sorry, I apologize. I couldn't get my hand up quick enough. So first, we would like to thank the committee for working on this bill. MDH was not involved or consulted on the drafting of these amendments, and so we just received them a few hours ago. And so, I reviewed them as best and as quickly as I could with the team as much as I could. It's a very complex issue, and so I didn't get a chance to do as deep of a dive as I would have liked to. But at first glance, there are a couple issues that jump out to us. The first being that the process outlined in the bill is not the standard claims process. For example, in B2, and let me get the actual page number for the group. In the reprint, it's page 4 of 5. So B2 Roman numeral 1. It provides 120 days to elapse, but I believe the current insurance law only requires 60 days. And there is no amendment to the insurance law that I could see. The second part, or the second thing that jumps out is that on the very next page of the reprint, it doesn't have a page number, but in Roman numeral 2, 1 through 3, that section effectively gives the provider veto over recoupment. If they don't provide written confirmation or agreement, then there's no payment. No payment can be rendered. And so, the department would really like to see that language stricken because, I think it was Ms. Doyle that stated they really want a fair adjudication. And this section is really one-sided and gives the provider the ability to unilaterally not confirm and then not have to provide any recoupment. In the next, in part 3 of that same section, it said claims have been, I apologize, the healthcare provider confirms in writing that claims have been applied correctly by the ASO. And that's not for the provider to decide. My understanding is that has to go through the Medicaid process. So that's not something that the provider can determine. On the same page, a little bit lower in 4, the first I, it says that the ASO has to identify, correct, and adjudicate the disputed claims. By law, the ASO cannot correct some of that information on the provider's behalf. If there's data entry errors, lack of authorization, additional information requirements, that's something that the provider has to correct and submit for reprocessing and readjudication. That's not something the ASO can correct. And so it's just in reading the bill, it just gives a little concern that it gives the provider every reason and avenue to fight the recoupment by extending timelines, by making MDH liable for attorney's fees. So there's no reason for the provider not to appeal. And unfortunately,
let me just interrupt you for a second.
Sure.
It was not mentioned, but the attorney fees are coming out. It's going to be taken out of the bill.
Oh, okay, great, thank you.
My pleasure. I thought that will make it a little better.
Yeah, thank you. And I guess just the the last thing is you know, the claims process outlined here, it extends timelines so much that I think this is actually going to provide more angst. It's going to make this go on and on for years to come. And certainly I don't think that's the intent. I don't think that's what anyone wants. So, you know, the last thing I'll mention is that, and I think it was Mr. Johansson that said this is a process bill, not a, I can't remember his exact term, but not a forgiveness bill or something like that. But, you know, operationally, this could result in forgiveness of hundreds of millions of dollars. And that's really a budget decision. So I think that it would be prudent to involve some of the budget committees as well. So I'll stop there. Thank you.
Thank you. I'm going to let Delegate Hill, let me allow Lori Doyle to respond to those comments, please. Thank you so much. Thank you for your flexibility. Ms. Doyle?
Thank you, Madam Chair. First off, I guess I would say that standard claims processes, there's nothing standard about what we're facing here right now. In the years since 1997, when the first ASO came in, we have never been in a situation where we had to receive estimated payments, advances, because the vendor failed. So this is an unordinary kind of situation to begin with. But I will say also that these claims were submitted and resubmitted and tried to get re-adjudication this whole time. That 60 days doesn't even apply. We have been trying to get these claims re-adjudicated since that estimated payment period. I will also point out that the bill does not give providers veto power of any kind. In fact, it says that after the notice is sent, at 120 days, you either have to say as a provider in writing that you agree with the amount, and so therefore recoupment starts, or if you don't respond, the recoupment starts. The only thing that would make the process take longer is if you dispute claims. And the whole point of this bill is to bring the two parties together and to say, we have to outline as providers, we have to outline exactly which claims we are taking issue with. Our hope is that we can sit down with Optum and work these things out. And I can tell you, no provider wants to get into a situation of having to go to the Office of Administrative Hearings and hiring counsel. It's expensive and it's time consuming. So this just provides some balance and some transparency to a process that has been, frankly, really, really troublesome and damaging to the provider community. Thank you, Madam Chair.
Okay, so now I'm going to go ahead. Heather, your hand is still up. Do you have a question? Okay, just want to make sure. So we're going to start with Delegate Hill, followed by Delegate Rosenberg.
All right. Thank you, Madam Chair, and thank you, Delegate Valentino Smith and Madam Chair for moving this along. I want to get some clarity about what the process would look like with Mr. Johansson's amendments. As I read it, this says basically that the provider would not be subject to a clawback unless a notice with this detailed information of, what claim are you talking about, how much you taken back and why. And I would think the why should be something other than just a number that just says, the numbers they usually give are pretty bad. So I don't know if the error that created the need for the recruitment is clear about with what the sponsor wants, because we often see a number that'll say something like denied because it was double billed or something, and it really doesn't explain, and you're still scratching your head. So that's the first part, but provided that this information is given, it says in at least 180 days have elapsed since that particular notice, not previous notice, are given. But then the next part says that the department can do a clawback after only 120 days if there has not been appeal. So I want someone to explain to me the difference between the 180 days that I'm being told, or providers being told your money's going to be taken back and you have a chance to appeal, and the 120 days when it says department can actually start clawing back. So that's the question.
Thank you. So
Correct.
who will be the best person to answer that?
I can give it a shot, Madam Chair.
Okay, thank you.
Okay, so it's a good question. It actually relates to kind of the point that Heather made. Okay, her suggestion was with this process after 120 days, on the second piece of your question, Delegate Hill, the department can only recoup if the provider confirms that, the money can be taken. But that is basically an exception to the 180-day rule. So you start with the primary rule, which is they have to send notice and wait 180 days. If after 120 days, the provider consents and says, yes, this is right, you can take it, the department can recoup then. If after 180 days, the provider has not appealed under paragraph 5 on that page, then the department can take money. So there's basically two cases where the department can go prior to the appeal. If after 120 days, the provider says yes. If after 180 days, the provider says nothing and doesn't appeal, then the department is free to recoup the amount that they had put in the notice. So the only way that the department would be prevented from recouping would be if the provider appeals prior to the 180-day initial time frame, and those specific appeals go to the Office of Administrative Hearings. And in that situation, the department can still recoup unless the provider wins, right? So the recoupment actually is set up to occur at any of those phases unless the provider prevails at the Office of Administrative Hearings.
Okay, and if I may, Madam Chair.
Absolutely.
So again, I think I understand what you're saying, that if the healthcare provider says, yeah, you're right, this was a double bill, this was an error, whatever, then at 120 days, or probably at any time they affirmatively say it, they can recoup the money. What I'm confused about is the 2I2, at least 120 days have elapsed and the healthcare provider has not refuted. So they haven't affirmed as in 2.2 or 2I, but they also haven't refuted, right? So what if they're just sitting there still thinking about it and 120 days go by? See, there's an or here. Like you said, you could confirm it,
yeah,
or you could not refute it. But if you don't refute it, that's still not 180 days.
If you don't refute it and you haven't appealed,
I2.
yeah. So it looks like you would be obligated in that 120 days to either refute, which is the informal process, or to actually have filed an appeal under paragraph 5.
So would you agree that that would need to be more clearly stated, because this would suggest that you have 180 days, and that second part says actually you only get 120 to do something, but you have to do something in 120.
I think if Aaron agrees, I think that probably makes sense to clarify.
All right, thank you. I think 180 is great. I'm not, and I think 120 is fine if someone confirms in writing. I'm not sure that you tell them you have 180, but if we don't hear from you by 120, we can go ahead and start the process. Doesn't quite make sense to me.
I agree with your reading on that.
All right, thank you, Madam Chair.
Erin, what do you think of that?
Yeah, so I would be changing the language in that 2I from 120 to 180 to be consistent, correct?
That's what I
Yes.
think.
I
Okay,
think that helps.
I can do that.
And then the other question was the first part where we talk about the error that created the need. Are we talking about a code, or we're talking about a written statement that says, you did this and this, and we have a claim from another time that shows that that person wasn't are we talking explicitly, or the same vague codes that we often see coming from insurers?
I can probably take a stab at that. Delegate, we've had issues with Optum since the beginning, not getting industry standard denial codes. There's a list of denial codes, as you're probably familiar with, that are industry standard, and you know the reason or reasons why your claim was rejected or not paid. And we have never had that. In fact, just recently, we've finally gotten a crosswalk from Optum around the denial codes. But for all this time, we have never known exactly why a claim was denied. So we need to know that, because maybe we can resubmit it, or maybe it's something totally beyond our control and we can't resubmit it. And we just say, okay, that claim is gone and we're not going to get reimbursed for it. And so that's what that wording is.
So my question, Ms. Doyle, is the language that says, and the error that created the need, does that actually say what you want to get? It seems vague to me.
Yeah, I guess whatever language would basically be best to refer to, you know, an actual
Like in plain lay language, right?
plain lay language, denials,
explain.
Right. The reason or
The
reasons, because
specific
the code,
reasons for the denial. Maybe Aaron, what do you think, Aaron? Something like that, or not necessary?
Yeah, we can work on something that's more, industry standard type terms. The reasons for the
questions. Those are my questions. Thank you.
Thank you. And Erin, I'll come back to you after we ask questions so that we can sort of clean it up a little bit to see what's in front of us, okay? We have Delegate Rosenberg next.
Thank you, Madam Chair. 2 questions. There was reference at the outset to review of the AG's office that I think reviewed the bill. Were there constitutional issues raised, and how have they been addressed, if that is the case? And then also, given that this is Thursday of Sign and Die Week, what is the status of the Senate crossfile?
So the Senate is waiting. I mean, well, my understanding from the sponsor here is that the Senate will look at this when it gets there, okay? Regarding the question, we received a letter from the attorney at the AG's office, Sandra Brantley, that basically said that as amended, and she has a caveat that she hasn't fully reviewed the contract in question, or do I have access to pertinent information? It is my view that there are no constitutional issues. As I understand, she says House Bill 715 as amended is simply changing the process and procedure for how an SAO handles a claim for reimbursement, not the SAO's entitlement to reimbursement. So she did find that given what's in front of her, that there are no constitutional issues.
Thank you.
My pleasure. Delegate Valentino Smith.
Thank you, Madam Chair. I just did want to clarify one point by the department. I know you have to speak in generalities. The attestation that this could cost millions and millions of dollars, I think, is misplaced. I think one need only look at the Behavioral Health Administration budget report that we were given an appropriation starting on page 23 to see the realization that we're not dealing with hundreds of millions of dollars. These are only the amounts that continue to be disputed in the estimated payment period. So I hope that that helps alleviate anyone's concern over that statement by the department. Thank you.
Okay. Is there anyone from the ASO from Optum that would like to be heard? Is there anyone here? Okay. Heather, would you like to be heard on anything that was said?
No, thank you. I'm good. Thank you.
Okay, great. Any other questions from the members or concerns? This is your time now while we have everyone here. Okay, Erin, will you tell us what's in front of us for a possible vote with the changes that we're submitting, including striking the legal fees and the technical changes that were given?
Yeah, so am I on mute or no? In the bill, on page 4 of the bill, in subsection B 1, Roman I. The lead-in would be on or after May 15th, 2022. MDH or an ASO sends the healthcare provider a notice that includes the recoupment amount, and then you would strike the 2 under there that would include the information specified in sections 10207 and 10208. And then in B2 Roman 1, the 120 days would change to 180 days. And then in the appeals process, on, I'm not sure what page it is now, but under the appeals process, you would not be allowing for attorney's fees for the providers.
Are there any questions from the members on those changes that have been outlined and described by Erin? Okay, so pretty clear. Okay, anything else, Erin? Oh, actually, there is a question, Delegate Johnson.
Thank you, Madam Chairman. On
My pleasure.
removing the attorney fees for the providers.
Because it will
I
make
was just
it,
wanting to know why, because this whole mess is not of their doing. And I just wondered why.
I appreciate the question. I've been told because it will make it more acceptable across the street.
All right. Thank you, Madam Chairman.
My pleasure. Being fully transparent. Thank you. Any other questions? Erin, go ahead.
No, that was all.
Okay, so on the amendments as Erin described them with the changes that are done, we're going to vote in concept. Is there a motion on the amendments?
Move the amendments.
Is there a second?
Second.
It's been moved by Delegate Bagnall, second by Delegate Johnson. Are there any questions or concerns regarding the amendments described by Erin Hopwood? Seeing none, all those in favor say aye. Any oppositions to the amendments? On the bill as amended, is there a motion?
Motion to move the bills amended.
Second.
It's been moved by Delegate Johnson, second by Delegate Bagnall. Any questions on the bill as amended? Seeing none, all those in favor say aye. Any opposition to the bill as amended? Okay, Delegate Chisholm, did you have a question? Okay, great. All those in favor say aye. Any opposed? Seeing none, the bill passes unanimous. Thank you for your time. We have one more bill to discuss. If we may, thank you everyone for coming on that, on House Bill 715. Now, Delegate Bagnall, you have the floor. And can you let the delegates know the bill that you're referencing to, please?
Thank you, Madam Chair. I'm referencing House Bill 935, which is the Behavioral Health System Modernization Act, which we had in subcommittee yesterday. We thought we were 100%. There were some concerns that were raised, not with the House, but they were raised by Medicaid with the Senate. That under the certified community behavioral health centers, that the language that we put in the bill requiring the Department of Health to seek authorization for expansion to all 24 jurisdictions would actually require a financial commitment. So Lori Doyle did reach out to Trisha Roddy to clarify that. And so we were looking to limit it to the five existing programs, which would actually change the waiver program to a 1115 waiver, which as I understand is SAMHSA granted, which would once again make it budget neutral. However, there were still concerns that it would not be budget neutral. So we wanted the opportunity to hear from the department as to what their concerns were, given that seeking the authorization does not mean that we have to do the expansion, and that the the determination of the expansion is actually in the wheelhouse of the department. And I hope that I clarified all of that. But I would love to give Lori Doyle the opportunity to expand on that, because she has been working all day to try and clarify the concerns.
Okay, Lori. Ms.
Thank you,
Doyle.
Madam Chair, and thank you, Delegate Bagnall. So the CCBHCs, we have currently 5 organizations that have received SAMHSA grants, Federal Substance Abuse and Mental Health Administration grants, to implement CCBHCs. And as you're probably aware, startup is always the costliest part of anything. So these startup costs have basically been offset by the federal government to the tune of $2 million a year. Usually they're 2-year grants. And these 5 organizations have been busy trying to get up, to speed. It's a pretty high standard to be a CCBHC. So the thought was we would compromise with the department and say, rather than do a statewide implementation, we would contain the implementation to these 5 organizations that are already going through this process, have received federal money, have put a lot of work in. We don't want to see this ball just drop when the grants go away because the state has decided not to pursue it. So when I spoke with Ms. Roddy, she said it was certainly better than statewide. They wouldn't have to go for a state plan amendment. They could go for an 1115 waiver because it wouldn't be a statewide issue. But when I heard the fiscal note, I was really astounded. First off, because these services that CCBHCs provide are largely Medicaid services. There's nothing new here. There's nothing different or new. It's just how they are provided in a more integrated fashion, and that the CCBHCs have to submit a budget to the department. The department has to approve that budget, and then they are held to it. So in many ways, it provides more budget predictability to the state than they currently have under fee-for-service. And the only final remark I'll make is that we've seen what these do in other states, and the amount of significant reduction in ED and inpatient utilization, and that's only 2 of the markers. There's lots of other things that these CCBHCs have accomplished. It would be a shame to lose this momentum. So we thought this was a reasonable compromise with the department. Thank you.
Okay, thank you, Ms. Doyle, for all your work on this and many other issues. We appreciate it. I would like Heather Scheck from the department to have an opportunity to speak with us regarding their concerns as well. Ms. Scheck.
Sure, thank you so much. So I apologize, I'm a little confused. The language or the concerns that I sent to Aaron this morning were based on the amendments that we saw yesterday, and that required expansion to all 24 jurisdictions. But it sounds to me now like Ms. Doyle and Trish Roddy had a subsequent conversation today to limit it to 5. I wasn't aware of any meeting between the 2 of them. And so I can't speak to that. But the budget language that I gave, the fiscal impact that I forwarded to Aaron this morning, was based on the amendments that we saw yesterday that said we had to submit a plan based on expansion to the entire state or all 24 jurisdictions. So I apologize. And I didn't know we were going to discuss this bill. Otherwise, I would have asked Tricia to join us.
Okay, so I guess my question that I have, and if I may, then I usually just let the members ask the questions, but in the interest of clarity and time, even if it's lower to 5, is there still a fiscal impact?
So my understanding, if it doesn't require a state plan amendment, according to Medicaid, even when we apply for a 1115 waiver, and we request an amendment in there, we have to provide we have to provide a funding source. So we can't just say we would like to do this, but we don't know how we're going to pay for it. So if we're being required to put in any sort of 1115 waiver or a state plan amendment, we have to provide a funding source for that expansion.
Okay. Are there any, thank you, Heather, I appreciate you. Are there any questions for Ms. Scheck? And I'm sorry, I go between your first name and last name because you and I work together so much. But Ms. Scheck, is there any questions for her? Mr. Martin?
It's not a question for Ms. Scheck. I just wanted an opportunity to comment, Madam Chair. So whenever you're done with Ms.
Yeah,
Scheck.
let me just finish. Yeah. Any questions from the committee members? Okay, go ahead, Go ahead, Dan.
Well, thank you, Madam Chair and committee. I really appreciate the opportunity. And again, I appreciate all the work that you all have done on this bill. The bill's been in subcommittee twice before now, and only after it was voted out yesterday, after heavy amendments, did we hear these concerns. The amendment that went into place yesterday didn't add this piece. This piece has been in the bill since it was introduced. This is actually something that was left over from the heavy amendments. Nevertheless, we've tried to listen to those concerns, and in the spirit of compromise, amended it down as Ms. Doyle mentioned again, so that all it would really require is for the Department of Health to apply for federal authority to continue something that's already happening. We just don't want to lose all the benefits that communities across the state are already receiving through the 5 existing CCBHCs, whose, like Ms. Doyle mentioned, startup costs have already been covered by the federal government. I know it's kind of a back and forth, obviously, in the last days of the session and stuff like that. But the number I think that Medicaid throughout, even on these, if we would just do these at 11/15 for these existing 5, I think they were communicating with the Senate that it would be about $150 million. And I'm very curious where that number comes from. These, as was mentioned, these sites aren't delivering gold-plated brand new services. They're services that to a large extent are already covered by Medicaid. CCBHC just modify how the services are integrated and paid for to ensure more coordination for the public, better outcomes, cost predictability for the state. And so I'm concerned that if we just kind of accept as fact the number the department has thrown out with no real justification, that's completely out of line with our actual experience in implementing these things across the state, that, not only we're not going to gain services, but we're going to lose what we already have. And so so thank you for the opportunity to comment. I appreciate it.
I have next Delegate Shaleka, followed by Delegate Bagnall. Delegate Shaleka.
Thank you. I just thought, Dan, I would clarify what they said. They actually gave some detail. If you look at the Department of Budget and Management's summary of the bill, they said mandates an appropriation of $15 million in FY24, $18 million in 25, $21 million in 26, and $24 million in 27. And each
that's
year,
a different part of that's a different part of the bill. I'm sorry, Delegate. Those are the peer recovery services that are completely removed from the bill. Those aren't even in there anymore.
Okay. So yeah, requires funding for 100 slots. So you're saying that's what it is.
That was taken out.
That's not in there anymore either. That's gone too.
Okay, and then the mandates appropriation of 150,000
out of there. That's going too.
24 and 250 and each fiscal year thereafter.
That's going too.
And then it goes down to, well, talk about other things. Okay, thank you.
My pleasure. Delegate Bagnall.
Thank you very much, Madam Chair. And just to clarify, for Delegate Shaleka, yes, all of the fiscal impact was struck from the bill. So we were working with what we believed was budget neutral policy. But I just wanted to circle back and clarify, and full disclosure, I did ask Trisha Roddy to be on this call, so I apologize, Ms. Scheck, that some of those wires got crossed. But because they were communicating directly with the Senate, I really wanted to have everyone in this subcommittee so that we could understand what the concerns were, because we were sort of hearing them second and third hand. But I continue to be confused as to this fiscal concern, because once again, as I understand it, applying for this waiver has no upfront cost. But correct me if I'm wrong. If Ms. Scheck can answer that, or Ms. Doyle,
Actually, Ms.
Trustee
Rowdy.
Rowdy is here.
Yes,
I'm
Delegate
here. I
Bagnall, let
apologize.
me, go 1 second, please. Let me
So-
just call on Ms. Rowdy. Ms. Rowdy, can you address these questions and concerns, please? And I know I have Delegate Chisholm who's waiting as well. Thank you, Delegate Chisholm, for your patience. Go ahead, Ms. Rowdy.
I apologize. There is a fiscal cost to when we apply to CMS. So when you apply and you submit an application, whether it's an 1115 waiver application or a state plan, they expect you to implement what you're proposing. It's a contractual agreement with the feds. And there's a lot of work that's involved in those applications, both at the federal level and at the state level. So they do expect you to implement what you request. So there is a fiscal cost associated with it.
And the question that we had earlier was a question regarding, now that it's reduced to 5, right? Is there a cost with that? Because the understanding was that it was budget neutral because these are, they're doing the work already. So can you let the committee know what is your opinion regarding that statement?
So there is a cost to it. We estimated, I think at a statewide level, it was over 700 million. If you lower it to 5, there's still an estimate for those providers. If you think about it, you're changing the payment that they're currently receiving. You're changing it to be either there's some different models out there. It's like an FQHC where you're paying a per daily cap rate or an amount, or a monthly amount. I think our fiscal estimate was based on a monthly amount. I want to say it was around $700 or so. So there is definitely a cost associated with it, even if you limit it to only 5 providers.
Thank you. I know that Delegate Chisholm has been waiting patiently and has not had an opportunity to ask a question yet. So I'm going to call on him.
Thank you, Madam Chair, but they started to answer some of my questions, but I'm still a little confused because there's so much stricken from the bill now. So when they do this fiscal note, it's assumed that either waiver, the 1115 or the other one, is going to be approved, and then the state of Maryland would have to put this into place. So that's where the fiscal note comes from, I'm assuming. And then my question is that federal funds and state funds, or is that just the state funds? Because that is still a huge number, regardless if it's all 24 jurisdictions or just 5.
Ms. Rowdy.
So there is a mix of state and federal. I think it's a little bit higher than it's probably around a 50% state share. Again, most of the services that when we implement something, we also implement it on the state only side. So it's not just offered to Medicaid recipients, but it's also offered on the state only side of the behavioral health shop. So it does, I don't have it right in front of me, but the fiscal note should be at least 50% state share.
And Madam Chair, if I could.
Absolutely.
Based on that assumption, if you apply for these waivers, are they granted the vast majority of times, and that's why we assume that the fiscal note will go into place?
Well, yes. I mean, so the federal government wants the state to be very serious about, they assume when you're putting this amount of effort into an application that you have the state share to implement the program. It's a lot of work, both at the federal level and at the state side. It will take us, if you were doing something on the 1115 waiver, it will take us over 6 months to get that approved by CMS. So again, it's a lot of work on their end as well as our end.
Thank you. That clarifies a few things for me. Thank you, Madam Chair.
Yeah, Delegate Bagnall.
Thank you, Madam Chair. And thank you, Ms. Rowdy, for being here. If you could just clarify something for me, because I know that you had spoken with Ms. Doyle and we were talking about limiting it to the 5 already approved CCVHCs. In my misunderstanding, it was my understanding that we were requesting with the waiver, we were requesting to, for services we're already being paid for, to extend that program, expand that program, and get those, CCBHCs to the federal standard. Am I misinterpreting that?
So what I said this morning was that it still has a fiscal cost associated with it. It lowers it, but there's still a fiscal cost associated with it. And we're not paying for it today, right? So there's grant funds that are supporting these organizations. So it is new cost. But what I said this morning was that lowering it to 5 definitely lowers the fiscal cost, but there still is a fiscal cost.
Okay. And Lori, this is the last comment. I'm going to be holding the bill. Okay.
Thank you, Madam Chair. Just a couple of comments. One, there's one of the things that CCBHCs are required to do is 24-hour crisis services, crisis intervention, mobile crisis. That is matched at 85%. And so the federal government has been saying, use your CCBHCs in coordination with your 988 plans, because you draw down this match and you coordinate with the services that people need to stay out of crisis. The other thing I'll say is that this committee and the Senate passed a bill that Care First and other carriers put in to create two-sided risk arrangements. And the whole thought was we can't just keep going on this fee-for-service level and not really looking at outcomes and looking at ways to control costs, but really also promoting outcomes. And that's what the CCBHCs are about. The department, the state gets to determine the basket of services. The state gets to approve the budgets, and the CCBHCs basically have to operate within those means. And that's how it works. So it's not as if it's runaway spending or we'll be doing all kinds of things that we don't cover now. That's not what this is about. So again, just a thank you for listening. It's a game changer and we desperately need it in Maryland. You can look at our ED stats and our ED boarding stats and you see what's going on with psych patients now. Thank you.
Thank you. So I'm going to hold the bill. I just wanted to allow the conversation as you requested, Delegate Bagnall. It does seem to have a fiscal implication. So I will hold the bill. We've done a lot this session with things that have a lot of fiscal implication. They're the right policy, right? However, this late into the session, we have to be a little bit careful. So we're going to hold it. I thank you all for your discussion. Thank you to the department for coming to the committee. You're always welcome. And thank you to the committee members for your willingness to have an open, respectful conversation. As always, I really appreciate everything you have done. And I don't know that we're going to meet again, but if we do not, I want to thank you for all your hard work. And when you get the end of session committee memo of everything that this committee has done, particularly in comparison to the entire General Assembly, and I think the House, you'll see that you did a lot of the work, a big chunk of it, and that it was good public policy, especially regarding behavioral health and access to care. So I want to thank you personally for allowing me to share this committee, and I couldn't do it without you. You have a blessed afternoon. We do have voting at 5 o'clock, so I'll see you then. Thank you.